Yes, maybe I just want to have the keyboard here. And so this is the image of healthy cities in Europe, and a lot of my insight in the world, theoretical, comes from my work with healthy cities. And as I didn't really know, I found it hard to gauge where you're coming from, whether you know anything about health or healthy cities or urban health, and that's why we were delayed a little bit, because we tried to explore together. Sharon needed to know more about Chetra, and I needed to know more about Regnet. So some of my slides actually are about health and healthy cities and how that has shaped my views and my research. And you will see on the program that I will talk about stages and cycles, and that, in my view, the political theory of policy making should really talk about juggling and weaving. It's an art and a craft more than a science, I think. How did I get there? Because I live by the maxim of one of my teachers, a man that was my PhD supervisor, but has amazingly trained. And his view of the world is there is a lot of stupidity. We would go to meetings and we would walk out, and he would grab his head like this and he would say, there is so much stupidity in the world. Why can't people listen to my wisdom? Now, the last part I don't necessarily agree with, that there's wisdom, but there is a lot of stupidity. And if you want to read up on my latest insight in how stupid we are, there's a book recently published on public health by my colleague Hanni Jankutong, and I write a chapter there about policy, practice, and health. And the question that I try to answer there, are politicians blind to public health evidence? And the case that I refer to there is the story of Edwin Chadwick and John Snow, champions of 19th century public health in Britain. They knew what was going on in terms of combating the cholera epidemic that was ravaging urban environments in Britain by the mid-19th century. And it took another 30 years before all of that insight finally was embedded in legislation. So maybe that is the time scale that we need to think about when we want to change things. So maybe we're not stupid, we're just slow. Go. Yes. There is more stupidity, and that is a stupidity around language. That between different parts of the world, there is sometimes not a lot of agreement on what terms mean. And my lovely colleague Paul Kearney, Scotland, he wrote a paper a little while back, actually, Gemma there rediscovered it recently, about the use of the term implementation. Because if you study policy, you have a particular idea of what implementation is. It's to make your policy happen. You put all the little parts of your policy in place. Let's go, let's solve the problem, because that's what you have policy for. Now, implementation in healthcare means something entirely different. Implementation in healthcare means following the protocol. So there's a protocol, if you have a patient with a certain disease, the protocol says you have to do this and this and this, and if you do that well, the patient will be cured. And one of the biggest challenges in healthcare is that clinicians think medicine is more an art than a science, so they go by their gut feeling and they don't follow the protocol. So implementation science has emerged as a field that looks at the implementation of clinical guidelines rather than implementation in a policy perspective. And I've always been stunned by the fact that those two worlds don't meet, that clinical implementation doesn't look at the work that always has been done in the policy world, and the other way around. Maybe we could learn from clinicians as policy scholars. As Sharon said, one of the things that I've been pursuing is to have a more political science-based view of the public health enterprise. And so, almost following Paul Kearney's perspective, with two colleagues, we wrote this piece, Health Policy, Why Research and How, and we argue for the establishment of a health political science. That doesn't exist, which is odd, because there's all sorts of other disciplines within the health field, health economics, health psychology, health sociology. Why wouldn't we have a health political science? And that's what we argue for in this article. And we just yesterday made a great step forward in establishing health political science as a legitimate discipline. Together with Patrick Fafard of the University of Ottawa, we launched Palgrave Macmillan series in health political science. And we agreed with Palgrave to publish between 3 and 5 books annually over the next 20 years. So if you have a book manuscript in the pipeline, please, it's not Patrick and myself that will write all those books. You guys will have to contribute to that. So that's my perspective. Now, one of the things that we need to establish is that when you look at health and health policy and health political science, we don't really know what health is. We think we know what health is. We all have a fairly good gut feeling about what health is. But people, especially people like us, scholars, we like definitions. We say you can only measure things if you have a good definition. So, what is health? Well, there's 4 perspectives that when I'm a little bit arrogant. So when I studied for my PhD, and I was studying whether it is possible for a government to make a comprehensive policy for health, so not care or pharmaceuticals or doctors, but can you make policy for health? And I was facing this question, what is health? So I decided to investigate that and found 600 different definitions of health. And then, of course, the question was, which one do I think is the proper one? I wrote, before I even did my PhD, I published a book on this. So these are my 4, the top 4. And you have to have the WHO definition, of course, because everybody, not everybody, but a lot of people would say, yes, the World Health Organization is the peak body in health around the world. They know what health is. But this is an ambition. That's not a definition of health. It's a state of complete physical, mental, social, and something to add spiritual well-being, not merely the absence of disease or infirmity. That's not a definition. That is something that you aspire to. Parsons, clearly a functionalist perspective on health. You know, health is what that you can do what you want to do. Then I'm going to skip the one here. The one that I like best is by Dubois, the man who also coined the term think global, act local. He said health is the expression of the extent to which the individual and the social body maintain the revenue and resources required to meet the exigencies of the future. It is, are you ready to cope with the fire that's going to break out here? Are you then ready for all of us, not just the individual, also us together, to get out of here and keep doing what we think is important in our lives? So for me, health is also an ambition, but it is relative, and it is we or you as individuals in social context, and it is about keeping ready for the future. It's not just me in the now, but it is a temporal dimension. Now that's, again, that's a definition, and you measure that definition, you can measure it, or the definition is whether you can measure it. But is this a definition that is relevant to policy, to politics? If you would go to the Department of Health here, would they say, oh yeah, that's health, that's what we pursue? I don't think that anyone in the Department of Health would ever think about what it is that they pursue. They leave alone, they want to pursue equity in health. Everybody the same health, or the same opportunities for health. But what health is, actually drives the agenda and drives the politics and therefore the policy choices that we have. I'm going to skip a few slides here, because health is complex. Henrik Blum, for the health people among you, Henrik Blum was one of the colleagues of La Framboise, and La Framboise was the scholar who supported Marc Lalonde in writing the Lalonde report in 1974 in Canada. First time a government anywhere around the world said, oh right, so health policy is not just about the allocation of resources to run a healthcare system, it's also about allocating resources to do all sorts of other things, looking at social determinants of health. So this is what Blum said in the early 1970s. He said, these things determine health. If we want to plan for health, these are the things that we need to focus on. Now, some of these are immutable, heredity. Well, certainly in the early 1970s, maybe now you can change genetic situations, but both of these actually can be shaped on purpose. And the width and the depth of different arrows actually mean something. How much they influence health. His view is that environment influences health much more than medical care, and his argument was that you need to invest much more in the environment rather than in medical care if you want to keep people, populations healthy. So, we've known this evidence, we've known this not just rhetoric, but also evidence-based for health policy for quite a few years now. It is not the Marmot Commission on Social Determinants of Health that has said brilliant things about how important it is to take a more comprehensive view. This has been an argument that's been around for quite a while. If you look at how things actually don't work out that well, you could look at, and that's because I have a background in healthy cities, in urban health, hidden cities. If you disaggregate data in cities to neighborhood level, you can see that there is a very strong relationship between those social determinants of health, in this case poverty, and the occurrence of all sorts of health issues, in this case HIV/AIDS in New York. Why is that? How's the causality of that relation? You get poor because you have a very severe, now mostly chronic disease, or is the other way around? Again, this is not new. This is not a new insight. I already mentioned John Snow, who actually found similar things when he looked at the causes of cholera in London in the mid-19th century. There's a John Snow pub, and the journal that I am editor-in-chief of, Health Promotion International, was established in that pub 30 years ago, and we're going to celebrate by having a good drink later. So that was quite significant. And everybody who has some kind of commitment to public health should actually visit and have a pint as well. Now, one of the things, one of my current projects that I'm starting up in health political science with colleagues from around the world, notably from Canada, so this is an Australian-Canadian thing, is how the word health actually is toxic. How health policy always turns out to be medical care policy. Why we can't get things right when we talk about health. We had a big conference recently in Brazil, the International Union for Health Promotion and Education met, and we had a couple of people in a very big room that said, well, actually health is not the right word. We need to maybe start avoiding the toxic H word. When you say health, people hear health care. This is not just a gut feeling that we have or an impression. There is evidence from a European health equity program. So there's an organization called Euro Health Net, which is committed to health equity through an organizational perspective across member states of the European Union. And they looked at policies for health and health equity across the EU. And they, in fact, found that when you talk about health, people hear health care. Now, you may say that's how bad is that? But when you hear health care, when you say health care or hear health care, actually, you end up with the medical industrial complex. That fuzzy complex of the pharmaceutical industry, the technological industry. There's more money going around in high tech and medical care these days than there's in the pharmaceutical industry. I wrote a book 2 years ago about consumer involvement in health policy, and we saw that billions and billions coming from the pharmaceutical industry are invested in consumer organizations so that they will advocate for certain types of treatments without them actually knowing them, oddly. But if you look at the economic landscape around pharmaceuticals and medical technology, the Siemenses and the Toshibas, the CAT scanners, the NMRs, the big machines, but also the very small technology that you use in everyday care for people, is a much bigger trillion-dollar industry that influences policy and politics much more than we actually want to know. So, healthcare is the medical industrial complex. There's huge interests that are driving health policy. So if we say health, we should invest in health, and we need to be concerned about health equity, we end up with resonances in belief systems of people of that medical industrial complex. Why is that problematic? Well, because the people who actually would be our supporters in advancing health equity, more health for everybody, opportunities for everybody, see health as a function of the money and the power that is associated with the medical industrial complex. So they would say, and that's what we've seen in our discussions with people framing our research ideas, they would say, if you ask us to invest in health equity, in fact, we need to get dirty hands working with that medical industrial complex, and they are too powerful. They have too much money. They are not interested in all the good things about health that we should believe in. So, and that's clearly a political question. It's not just a policy question. It's a political question. Now, before I go into the policy weaving and the juggling, I thought I should share with you some of the tenets, some of the principles of healthy cities, because Sharon said, not really a mother, maybe a distant cousin. But Healthy Cities is a WHO program that was started in 1986 and has different shapes and forms in different places around the world. But there's, to our most recent count, there are about 15,000 local governments that in some way or another have signed up to the ideas of healthy cities, some more firmly through council decisions than others. But I thought I should tell you what Healthy Cities is all about. So it's not about investing in health care, it is not about doctors, it's not about the medical industrial complex. It is about making healthier choices, easier choices. And if you want to read up on that, there's a little book. It's only 40 pages, so you can consume this at your leisure. And in that little book, the evidence of what creates healthy cities was looked at, and they came up, Trevor Hancock and Leonard Gould came up with 11 qualities for healthy cities. If you want to be a healthy city, if you want to sign up to this value system, these are the 11 things that you need to aspire to. So you need to work toward all of these 11 qualities. And over time, I've done a lot of research with lots of colleagues from around the world to see whether these healthy cities actually do this, what determines whether they can do this, and whether if they do it, it will have any effect. And fortunately, over the last 30 years, we can now start to see some of the impact of adopting these qualities on health and health experience particularly. I'm not going to read all of those out, but what you see is that they are very value-based qualities of healthy cities. A stable ecosystem, a participatory community, an economy that supports what people want, connectedness with the past, that you know where you are, and that has a lot to do with the legibility of the urban environment. That you know where you are in the city, that you're part of it, and that you can predict to some extent what a city will do for you. And it is in healthy cities, in investigating these things in local governments, that we came up with a number of new stories, insights that I'm going to share with you in the rest of this presentation. So, the next slide is about the more traditional way of looking at policy, and I'm sure most of you will have seen the more traditional way of thinking about policy. It's a rhetoric, it's a mantra that is standard in policy circles here in Canberra, but also at the local level. Policy making is not linear. It's not you start with a problem and you solve the problem. No, clever people say it's a cycle. So I want to start, ending up with weaving and juggling, I want to start with policy cycling. So these are the different stages in the policy cycle. And if you, in fact, look at the literature, it's amazing how many different stages in the policy cycle people have identified. As little as 3, and as many as 20 different stages in the policy process. We were asked, Dorothee Peters and myself, we were asked by the World Health Organization to turn the policy cycle into a checklist. So if you want to give this to local government and make what currently in WHO is called health in all policies, so not just in the healthcare system, but also in housing, justice, the economy, community development, what are the questions that you need to ask? And so we looked at the literature, we found all of these stages, we thought, well, this makes sense. And then we found that actually the cycle goes both ways. If you talk about implementation, once you define the problem, you have already thought of implementation. It's a bit like the Heisenberg uncertainty principle. You never really know what you're looking at. You can't look at this discretely from the rest. So by defining the problem, you have already thought of implementation parameters. Maybe you haven't decided exactly what implementation is going to be. And the other way around. Once you start thinking about a political strategy to adopt certain implementation parameters, you are remorphing your definition of the problem. So yes, we did make a checklist, and we published a checklist, and we discussed this with local policymakers. So around the world we tested this, we sent it out to 500 local governments, and we said, would this work? Is this sensible? Would you apply this in your policy making efforts? Is it too unwieldy, too difficult? And they said, yeah. So this is right, but there's no order to these things. Actually, if you say A, B, C, D, E, that suggests that there is order to this, that you can actually cycle this nicely. What you have to do was the feedback from the practitioners. So this wasn't us thinking it. The practitioners told us to actually do this well. You have to think about all of these questions at the same time. And that makes it unwieldy, because that messes with your mind. You get very confused about thinking about all of these things at the same time. So we thought, wow, that is interesting. What then, instead of a cycle, would be a good metaphor for thinking, for encouraging people to think about everything at the same time. And that's how we got to the juggling idea. So juggling is not just playful, and people do this well. Juggling requires discipline. Juggling is keeping all the balls in the air. So if you know the rules of juggling, you have to keep your balls on the air, but it's also a matter of reflexes, catching balls, throwing them almost by instinct, knowing where a ball is before you're going to catch it again. That is a much more appropriate metaphor for the policy process, we find. So in training local governments, thinking about the policy process, we actually found that this is a much more sensible way of discussing policy questions with bureaucrats, but also with politicians. Particularly politicians recognize this, keeping all the balls in the air. You know, a politician really wants to do that. And again, you know, if you drop your balls, you can pick them up and try again. So it is about juggling. What is interesting was that last year, Michael Howlett didn't look at juggling as a metaphor. He reviewed with some colleagues work by John Kingdon, which is particularly in the health field a very popular theory. If you actually look at it, and I want to do a systematic review of the application of John Kingdon's work, because most of the pieces of research that are published will say, we have used John Kingdon to do this. They actually haven't. They just say, we use the multiple streams theory, and then they don't. It's more of a symbolic attribution of multiple streams than that they actually investigate Kingdon, and I will come back to that. But Michael Howlett and his colleagues actually looked at Kingdon from a slightly different perspective and said, in fact, it is not just about streams. It is about different realities, different perspectives on realities that weave in and out. So rather than 3 streams, they found 5 strands, and they actually, apart from policy, problem, and politics, which are the traditional Kingdon streams, they added process and program. And these weave in and out of each other all the time. So it is not, like Kingdon said, the metaphor that Kingdon uses is to connect these streams, opening windows of opportunities. Actually, it is, and it's not even weaving in my reading of this article, it is about knotting. So it is not knitting, but knotting. To create knots at critical junctures, to see in your juggling of all the different factors how things come together and how you stabilize, how you knot the different elements of that process together. And Howlett and his colleagues actually identify them as critical junctures. So it's not just one window of opportunity that opens. They say there's 5 critical junctures in this weaving process that gives you an opportunity to stabilize the process and move it forward. If you don't take the appropriate action at any of those knots, those points in time in the weaving, you lose the plot. You lose the opportunity to actually make policy happen, formulate it, to firm it up, to formalize it, and to implement it. Now we come to the crunch of what I want to tell you. So, Kingdon, and I assume that you know what Kingdon says. Kingdon says there are 3 streams. Howlett says actually there's 2 more that weave in and out of this. Problems, politics, and policies. And when you actually read the book, this is the 3 arrows are a gross oversimplification of reality. There's much more going on. There's no linearity. There's no, it doesn't happen. You know, when you read in the health literature, and there's a lot of stupidity, and they tell you this. The health people say, yes, there's this continuous flow. And there's a linear logic to it. In fact, when you read this book and when you try to cut it up into discrete stages or elements or parts, there's much more that feeds back, that goes, that can disconnect, that can reconnect, that is morphed, that needs to be in place as preconditions for other things. So the idea of 3 discrete streams that just keep quietly flowing like the Amazon through time and then connect in some magical way, nah, not really. But, you know, theorizing means making an abstraction of reality and reflect on that, so let's do that. Wake up. There you go. What Kingdon also says, apart from all those little boxes and the arrows in between, is that in each of those streams you have legitimate actors, people who have a formal role in thinking, talking about problems, but also people who have a more hidden or invisible role in shaping that stream. For instance, problems, that's our business. As academics, we love to think about problems and we identify problems, we write about problems, but our funders shape the way we can think about problems. Certain problems we're not allowed to think about because there's no money allocated to start thinking about certain problems. Or we can think about them, but we won't have the resources to actually do something about it. Equity, in many respects, is one of those issues. We find it incredibly hard to find research funding from NHMRC or ARC. For Chetra, maybe you have a very lavish funding source, but so our funding, research funding, comes from local government, which is less credible funding for your research than ARC does. So that shapes how the problem can play a role in that stream. So there's visible and invisible participants, and it makes sense to be aware of that. Now, in the naive version of Kingdon's multiple streams perspective, you read the health literature, they say, yes, what happens is that there is a policy entrepreneur, and the policy entrepreneur is pushing, and then the policy entrepreneur, when he connects the streams, opens a window of opportunity. Ta-da, everything fixed. Well, so we looked at that, and 20 years ago, my first question in research that I did with a small research team in the Netherlands was, can you in fact identify these policy entrepreneurs? are they there? And for a policy to have happened, can you identify what, if any, what that policy entrepreneur did and how they morphed all of that? Well, in fact, policies happen without policy entrepreneurs. And the other way around. There's policy entrepreneurs, self-identified people who say, yes, oh yeah, I'm a policy entrepreneur, who are completely ineffective. Nothing happens. So in that sense, the multiple streams theory is maybe a multiple streams heuristic, thinking about stuff, rather than a theory that allows you to predict things. So that for us was an interesting finding. And this is not to say that the multiple streams theory and its ideas are useless. I think, as a heuristic, they are very sensible to think about how the world works. And I will show you why that is, I hope. So one of the things that we found was that if you combine England's multiple streams ideas with policy network theory, so the picture that I showed you before with all the little boxes and feedback loops suggested to us that actually Kingdom, there would be added value if you would combine this streams idea with a policy network idea. Can you identify what the actors and actants in Latour's terms, what are their connections? And can you shape those connections? If maybe a policy entrepreneur is a group of organizations or is a phenomenon rather than an organization or an individual that shapes the policy agenda. So we try to map the policy network within the cases that we looked at. We were looking at a number of local governments and their efforts to make health in all policies. And we discovered that yes, you can map those networks. You can actually identify who's there and how they connect to each other. But one of the valuable things that I have discovered over time is that if you discuss your findings with the practitioners, like I said, that policy cycle, and we sent it out from WHO to local governments, and we said, does this make sense? We did the same thing here. So we made a policy network, and we gave it back to our local informants, and we said, does this make sense? Is this sort of view of a policy network, is that a reflection of your reality? And they said, no, not really, because the network around problems looks very different from the network around policies. Some actors, some agents at the local level felt that they were not empowered to engage in the politics of the policy game. They felt empowered to talk about problems. Anyone can talk about problems. But they didn't feel that they had a role in shaping the politics, or leave alone the policies. So they said, we think there's a different network when you talk about problems than there is when we talk about or engage in policy alternative ideas. So we thought, maybe we can separate those networks. Maybe we can map around different ideas, different kinds of networks. Would that make sense? So we tried it, and yes, we could. So we developed, based on this idea that actually there are different networks, so you can separate the one overall network. You can separate that out into a problem network, a policy network, and a politics network. And we ran an online tool with two local governments. So the idea here is that people sign up. This is on the intertubes. You sign up. You say, I'm interested in playing the game of policy development. But this is a real game. This is about real things, about real issues. So I'm signing up, and I can invite others that I think should be involved in this too. So the local division of general practitioners would say, yes, we're interested in having more policy. We sign up, we go to the website, and we are going to answer these questions. But we also want the local government, the municipality to answer those questions. And we also want the housing corporation to answer these questions. So you snowball through an interactive device on the internet, you snowball your respondents to this thing, and you can self-select. So this is the opening screen, and then you say, I am actor A. And then you enter some network data. So how often have I seen all the others? What have I exchanged with them? Resources, knowledge. How close are we to them physically, but also in terms of our understanding of the problem. And so say this is social work. This is the municipality. So all of this is self-selecting, and it will get more complex over time, because people will hear about this, they will think, well, I should be part of this, because they're doing stuff and I can't be left out. You ask the questions, you can even add more actors, the different logos here mean different things. And then over time, you could actually see how different networks look. So between problems, politics, and policies, they're different. And here you see in policies, the policy network thinking about the solutions to the problems. This yellow one here is disconnected. So showing this to the network actually makes them aware that, I think I'm involved, but in fact I'm not involved. So maybe I need to do something. And look, I may be disconnected in policies, but I am connected in problems. So therefore, I'm entitled, I have a legitimate role in talking to these others, or I need to seek connections with others. And over time you can actually see whether that commitment, whether that engagement has made a difference. And you can see how the different networks move over time for all of those actors. So you shared your data, you look at all the other actors, and you think, actually I've moved closer to the center. And one perspective on policy network theory is that the shape, the configuration of the network says something about the outcome of the policy. And you can imagine that if the local government is more central than the Chamber of Commerce, that a public policy perspective will be more important than a more industry-oriented perspective. Now, what we wanted to do was, and this was just collecting lots and lots and lots of data, and then based on all the data that we had collected, predict what changes in the problem stream would have an impact on the policies. So if you, as a policy entrepreneur, morph the problem network differently, if you say, for instance, so I move these folk here, I connect them, that's my role as a policy entrepreneur. I can engage, I'm entitled to engage in the policy, in the problem stream, that's okay. So if I do that, then we know that the others will respond to that. We know that the others will think, ooh, something's happening, we need to be closer to the center of the action. And just by having millions and millions and millions of data, we were wondering, can we find an algorithm that would then predict how that changed configuration at the start, over time, will influence the policies? Will the configuration of the policy network change as well over time? You see here that it looks now different than it did before when we didn't intervene. So the idea was just big data. If we have lots of data, because there was no way that we would know, at least we didn't have the intelligence to predict what would happen if we would morph the problem network in a certain way. So we tried this. It was incredibly popular. And we tried it out in Geelong. So before I think Signal was in Geelong. We tried it out in Geelong. Local actors thought that this was fabulous, this was fantastic, because they actually saw where they were in the game. They knew their position, they knew how well connected they were, they could invest in their own position, they could invest in their argument, they could invest in their work. So they thought it was brilliant. In order to collect all of those data, we thought it would be a self-organizing chaos. That you could just run this and the data would connect itself, and then over time you would have all the data and we would find out the truth. So we would be a little less stupid. Actually, what happened was something that we found morally wrong. And we had to pull this, so it's no longer alive. What happened was that those that are already more powerful can manipulate the system better than the people who actually would need it for health equity, for instance. So industry can invest more. Industry can be online all day long. They appoint someone and they say, play the game all the time, every day, even on Sunday evening. You're going to play the game, you're going to monitor what everybody else is doing, and you will anticipate. So it would only work, so the data collection was okay, we could collect millions of data, but without moderating the system, it increased inequity, we felt. So we couldn't continue. We had to find money to moderate this, to have someone who controlled what was going on, which is also a policy entrepreneurial role, but we didn't have the resources. We simply could not afford to do that. So it was pulled. Yep, I'm nearly there. So, what we learned, yes, it is possible to connect the disconnected, which is what you want if you want to pursue equitable health policies, in our case at the local level. But we could only do it in moderated environments where we moderated the interaction to make it a free-for-all, to have it run into self-organizing chaos, actually advantaged the powerful. Those that could manipulate the system the best would have the greatest advantage of seeing that configuration. Also, as I said, and I'm happy to discuss that in some way, either now or over email with any of you, does this make sense? So this theoretical idea that you could separate out a policy network into three ideational perspectives, problems, policies, and problems. And how would you then determine whether influencing the shape of the configuration of one of them impacts on the shape of another one? Does that make theoretically, well, theoretically, at an abstract level, it makes sense, but how would you turn it into a theory that would allow you to make predictions? If I do this, over time, that will happen. And maybe, again, that will take 30 years. You don't know. But the good thing here was that those practitioners, the people at the coalface, loved it. They thought it was fantastic. They really saw the serious daily quality of this. They thought it was was something very, very, very nice. I'll leave it there. Yep, I have other graphics and tools and things, but yep.
Thank you. I'm sure that we can love it.
Yeah.